This conference will now be recorded.
All right, the floor is yours.
Okay, well, thank you very much, Kevin, and thank you so much for inviting me to do this. I'm always excited to talk to the people that that really matter in this, the people that I see, and I really learn so much every time I meet an individual who has sarcoidosis because it's such an enigmatic disease. It affects people in so many different ways, and the challenge for not just me as a physician, but also for the individual is what do we do about it? We got the sarcoidosis. Do we treat it or not treat it? Because a lot of folks do get better on their own, and that is really the big question. So thank you for inviting me. And I'm just going to show a few slides. It's not going to be that long, just kind of an overview and maybe stimulate some questions that I'm happy to answer after we're done here. So just a few disclosures. Every time we give talks, we'd have to say this. I'm involved in some industry clinical trials. There's one from Novartis, which I'm very excited about. It's with a new biologic that might have good effectiveness in sarcoidosis. The biologics are wonderful medicines. You see a lot on TV for asthma and so on, but they tend to have very good side effect profiles. They can be used for a long time, and they're very targeted. So I'm excited to be, and hopefully they will select us to participate in this one. And I'm also in other trials with separate conditions that are called pulmonary fibrosis, idiopathic pulmonary fibrosis. And as Kevin mentioned, I have support funding from the Foundation for Sarcoidosis Research, and I'm studying to understand better why some folks with sarcoidosis get scarring of the lungs and other folks get better. That's an enigma that really has been out there for a long time, and it would be nice to predict who gets better and who doesn't, so we can know that up front and we can do our treatments from there. This is the definition for sarcoidosis. I'm sure you've seen many of you have already understand some of this, but let me just walk through this because I really want to use this definition to set the stage for tonight. So sarcoidosis is a multisystemic disorder. It affects many organ systems, okay? It's characterized by this specific type of inflammation called granulomatous inflammation. The cause remains unknown. I say here the clinical presentation is protean, meaning that individuals present with a variety of signs and symptoms. They can be very mild, they can be severe, and sometimes we find it by chance. The person is getting a chest X-ray for a new job or for a cold or for something else, and lo and behold, there's something there that points to sarcoidosis. And once we find the sarcoidosis, the big challenge then becomes, what do we do with it? Okay, we got it. So what I like to tell folks is the only thing every one of you with sarcoidosis has in common is this. Right here, what you're looking at is a biopsy from the lung. It's magnified about 500 times, and what you see in the middle here is a granuloma. This is a granulomatous disease. It's this little spherical inflammatory nodule that's fighting something that you breathed, something that came into your body that we don't understand what it is yet. Have some ideas and some guesses, but we don't really have it nailed down. And the granuloma has here, you're looking in the middle, is this thing called a giant cell. This giant cell is the cells in our body that are called macrophages. They're policing for infections and things like that. They kind of get together and they bind and they form this big giant cell with a bunch of these little blue dots in there, which are the nucleuses of the cells. Around that, you have what we call epithelioid cells, and these are kind of the factories of the granuloma. They make a lot of chemicals, if you will, a lot of substances that drive the inflammatory response in granuloma and produce the symptoms that many of you will feel. And then around the outside of the granulomas, these very dark blue spots, these are the directors. They're like the directors of the symphony. These are the T cells. Sometimes we call them CD4 cells, CD8 cells, and they kind of orchestrate how strong the inflammatory response is going to be in sarcoidosis and whether it's going to progress or whether it's going to recede. So clinically, it manifests in so many different ways, but the bottom line, when we get the tissue, whether it's from the lungs, the liver, you name it, you're going to see these granulomas. I always like to talk a little bit about Mr. Mack here, Bernie Mack. Mr. McCullough was a comedian and an actor, and he suffered from sarcoidosis. He had quite a severe case of pulmonary sarcoidosis, and sadly, he developed a pneumonia, and it took his life at a very young age. And this is the thing about sarcoidosis that I like to point out. Many diseases, especially lung diseases, tend to be more categorized like emphysema, COPD. It's going to happen later in life. The other things tend to happen in different parts, but sarcoidosis can happen at any time in our life. It's uncommon in children. We do see it, but typically it hits people in the prime of their life when they're out there working, they're raising families, and there's a lot of stress and so on. So we have to keep those things in mind. But Bernie was an amazing actor. In his last movies, he was actually off stage. He was taking oxygen on the side to regain his composure and get back into looking, perfectly normal and happy during the movie. Sarcoidosis is found all over the world. Okay, and this green wedge that you're seeing here in the middle is to depict what I like to say the severity, because it can present in so many different ways in people with sarcoidosis. It can be very mild, it can be quite severe. So here, for example, in European Americans, we have about 11 per 100,000 in the population will present with sarcoidosis. In African Americans, it's about 3 times higher, about 36 per 100,000. And probably we're seeing it in a higher prevalence in African Americans because it tends to be a more severe disease. The African Americans tend to have a more robust response to whatever is out there that's causing the sarcoidosis. So we're gonna see it more often in those individuals. In Europe, for example, here in Portugal, there's very little incidence, whereas in Sweden, there's a high incidence. Probably a lot of it is because we're not really looking for it in some countries. In Sweden, young people go into the military, they get a chest x-ray, and lo and behold, there's an abnormality and they have sarcoidosis. So just because the prevalence is high doesn't mean that the disease is severe or causing a lot of problems. In Asia, the Japanese see quite a bit of sarcoidosis, and in fact, a lot of the very good studies and a lot of what we understand about sarcoidosis comes out of Japan. In Korea, other granulomatous diseases like tuberculosis are more common, so we don't see sarcoidosis as often. And then here in Africa, you're seeing, particularly in South Africa, the tip of Africa, again, like we see in the States, we see it more prevalently in Africans than we do in the white population there, again, because of the severity of the disease. As I'm sure you all know, and I've said, is that sarcoidosis can affect any part of our body. In the lungs, it affects 90% of the time we're going to find it in the lungs. And because it's a disease that we mostly find in the lungs, it's something that we in pulmonary medicine have taken on board as the primary people who do deal with sarcoidosis. And as I'll show you as we move along and get near the end, although we do direct the therapy or treatment of sarcoidosis, we really need the help of our colleagues in other areas such as cardiology, neurology, to deal with sarcoidosis affecting those organ systems. And you can see here, for example, it affects the eyes in many folks. Eventually, you're going to see that about 50% of folks are going to have some involvement with the eyes. It can affect our brain, etc., the kidneys, the muscles, and so forth. So I'm just going to walk through a few of these organ systems and talk a little bit about them before I finish up and engage with you all there. Okay, so I said it's a disease most common in the lungs, and let's start with that. So back in the 1950s and 60s, a gentleman called Dr. John Scatting looked at a large series of patients with sarcoidosis at the Brompton, this is in the United Kingdom, and kind of segregated them out by the way they presented with their chest x-rays. And he was able to roughly guesstimate, if you will, who was going to do better or not. And he developed this Scatting staging system, to which we still use today because it is quite helpful. Now, so here in stage 1, what you're looking at, this is a chest x-ray, okay? In the middle, we have the heart, and on either side, we have the lungs. This is the right lung, this is the left lung, which look perfectly normal. And then you see these bulging things over here on either side, and those are very swollen lymph nodes. Sarcoidosis is a disease that courses through our lymph nodes and through the lymphatic system. It's a highway throughout our entire body that's very important to protect us against the elements, to protect us against infections. It's called the lymphatic system. And so these granulomas and these inflammatory cells in sarcoidosis course along those networks. And the lymph nodes are kind of like the different way stations. That's where the trains stop. And so here we see these big juicy lymph nodes, if you will. We call them potato nodes. They're huge. They're on either side of the heart, and that's called the hilum. So that's called this is the right hilum, that's the left hilum. So we say this is hilar adenopathy. So Dr. Scatting found in stage 1, people who just had hilar adenopathy, these individuals, if you watch them over time, they tended to get better, most of them, okay? He also recognized what he called stage 2. In stage 2, in this case, this is one of my patients from long ago, the same patient. You can see that the lymph nodes are still swollen on either side of the heart, but then you're seeing some more stuff going on in the lungs. Okay, these are what we call interstitial infiltrates. And so what Dr. Scatting found was that in folks who had two things, they had the lymph node swelling, and then they had the infiltrations in the lungs. He called that stage 2, and he found that maybe about half of those individuals got better on their own, and the other half progressed. They would progress perhaps to other stages, perhaps to this stage 3. Okay, and in stage 3, you can see that the lungs, all this fluffy white stuff on either side, on the right lung and the left lung, but the lymph nodes are no longer swollen. The lymph nodes seem to be back to normal, and he called that stage 3. Turns out that maybe a third of those individuals would get better, and 2/3 of them may progress further. And then the final stage that he recognized was a stage 4. Stage 4, you can see here, it's involving both lungs. You can see the lungs look a little bit smaller, they're more restricted, and then there are these harder images here which describe scarring in the lungs. Scar is forever. Once a person gets to stage 4, the lungs are scarred, and reversibility is not an option in that situation. And so these 4 stages is what Dr. Scatting described. Now, we hesitate a little bit here because when we say stage, it implies that people start out by 1, then they go to 2, then they go to 3, and they end up at 4. But no one really knows if it's really this pattern. And more recently, people who do sarcoidosis, like myself, really want to call this type 1, type 2, type 3, and type 4, because it could very well be that a person might start out like a stage 3 and then devolve and go back into these other stages. No one really knows. So take that with a grain of salt. When we say stage, and you may be a stage 3, please don't say, oh my goodness, I'm going worse and worse and worse. We just don't know that for sure. And in fact, we even have a stage 0. Okay, this is a stage where there's no evidence whatsoever of sarcoidosis in the lungs, but yet if I go down into your lungs with a bronchoscope and take little pieces of lung tissue, about 50% of the time I will find those granulomas. So let's say you have sarcoidosis on your skin or in your eyes or in your liver. If I were to go into your lungs, I would probably find it there, even though we don't see it by x-ray. Okay. So I would submit to you that if we find someone who has sarcoidosis on the skin, if we really, really look hard and go into the lungs, we would probably find it in almost everybody who has sarcoidosis. It's not, if the lungs are not involved, and it is a mildly risky procedure to go into the lungs with a bronchoscope, and we just don't do that willy-nilly. We don't want to put people at risk just to prove a point. So the lungs are involved in, I would submit to you, almost on everybody who gets sarcoidosis, and we believe that the sarcoidosis starts there and then courses through those lymphatic networks throughout the body, because that's where the lymphatics go. Here is an example of what we call sarcoidosis, ocular sarcoidosis. I tell my residents and fellows, I say, don't think of sarcoidosis of the eye, because it involves more than the eye. It's the ocular region. You've got the lacrimal ducts where we make our tears. All parts of the eyes can be involved. It can be the iris, the colorful part of our eyes, the conjunctiva, which is the lining around our eyes. The white part of our eyes is called the sclera, and that can be inflamed. And then the inner part of our eye, which is the uvea, is very commonly involved in sarcoidosis. And our ophthalmology colleagues are very important people to help us in managing ocular sarcoidosis. And it's really, really important. If I find sarcoidosis on your skin, and you tell me you don't have any eye problems, I'm still going to send you to the eye doctor, because lo and behold, it may be there. If it's there, we got to treat it. If it's not treated, it could actually cause blindness. So we really need to understand what's going on in the eyes. The heart is really important, and we're recognizing these days with more advanced technologies, which we call the cardiac MRIs and PET scanning of the heart. We find that the sarcoidosis does involve a heart. Most of the time it's going to be, you can see here, 73% of the time in the middle part of the heart. This is the septum, the muscle that separates the two powerful ventricles which pump blood through our bodies. It's the left atrium is the big muscle, and then another muscle which is a little bit less big is the right atrium, right ventricle, which pumps blood through our heart, through our lungs rather. If we have sarcoidosis in the wrong place, here, right here in the middle, this is where the electrical system of the heart starts, the AV node. The sarcoidosis can inflame it. It can cause heart rhythm problems. We can have sarcoidosis if it inflames the muscles of the heart. It can make the heart beat poorly and can cause heart failure, what we call congestive heart failure, cardiomyopathy. So we have to be very careful about the heart. And when we examine someone, again, they come to me with skin sarcoidosis. I want to understand their heart. Are they having palpitations? Are they having shortness of breath? Are they having skipped beats? Are they having difficulty lying down and breathing? And so it's very important to understand cardiac symptoms. Are they swelling in their legs? And to get an EKG, it's mandatory. Eye exam and EKG is like everyone, no matter where you find the sarcoid, you got to have that, because we want to understand the rhythms. We want to understand if there are any problems, and we need to pursue that any further. Very important. Cardiac sarcoidosis, it's a toughie. We really have to treat hard and long, and the treatments are not gentle, as you may understand, with steroids and these other medicines. It can affect our nervous system. It can affect our brains. So all of these white areas here, right here, and here demonstrate on magnetic resonance imaging places where the sarcoidosis is affecting the substance of the brain. Okay, it can manifest in many different ways. It can affect our spinal cord, and here we have this white imaging here. It shows inflammation in this individual spinal cord. We see a little bit of here. The darkness is normal spinal cord, and then these areas here where you see some lightening, those are areas here where there's some sarcoidosis involvement. So it's very important to have our neurological colleagues involved. And like cardiac sarcoidosis, this is a very difficult to treat and can take a long time to get under control and help people. This is an example of sarcoidosis affecting the lining around our brains. It's called the dura, is the lining around our brains right here. And sometimes sarcoidosis can even look like a stroke, for crying out loud, right? I mean, this is vascular involvement. It can cause a vasculitis in the vessels in our brain, and it can look a lot like someone might be having a stroke. Here we see this in the cerebellum. This is where we get our balance. Another cerebellum. This is up here in the frontal lobes of our brain. So it can affect everything. It can also affect what we call the peripheral nerves. So out of our brains and out of our spinal cord, this whole network of nerves come out to our arms and legs and our face in different parts of our body to control our movements and so on. And we have what are called a set of 12 cranial nerves that run how we move our tongue, our lips, our eyelids. And this is the facial nerve. This is the seventh nerve. It's called the facial nerve, which is the most common cranial nerve affected in sarcoidosis. And then anyone who does sarcoidosis is going to see this several times during their career. And these individuals are demonstrating for you very kindly what it looks like. For example, in this individual, we're asking him to kind of grimace and kind of smile, and you can see this is the normal side. You can see the forehead is able to wrinkle. He's able to close this eye. He's able to smile on this side, but the entire left face on him is paralyzed, right? He can't move it, and in fact he can't even close his eyes. So we have to worry about dry eye in these individuals and really keep them moist and sometimes covered, and until we can treat the sarcoidosis and to resolve this. And this person over here, he has the facial paralysis on the opposite side, on the right side, and he's able to smile here on the left and so forth. So the nervous system can be affected widely in sarcoidosis. The skin is a common place that we see it. On the face, we call it lupus pernio. It's not lupus disease. And you can see these kind of rolled up, very shiny lesions here, purplish lesions here on the nose, here and here. There's another spot here, another spot there. And if you biopsy those areas, you're going to get tons of granulomas. They're just packed with the inflammatory granulomas, looking like what I showed you earlier on. It can present as a plaque-like lesion. These lesions are not scaly. They're not like psoriasis. They're not itchy. They're not really inflamed. They don't really hurt. They're just very impressive. They're a little bit raised. They're darker, a little bit darker than the person's skin color. Those are the plaque-like formations. They can happen anywhere else on the body other than the face. And this individual is displaying what we call papular sarcoidosis. You can see these pinkish lesions kind of on their body as papules, little isolated, rounded, nodular things that are raised up. And if you biopsy the papules or the plaques, you're going to get tons and tons of granulomas in these individuals. Well, another interesting phenomenon, which I've seen fairly frequently, is in folks who get tattoos. The sarcoidosis, when it flares up, can actually flare up around the edges or inside of the tattoos that people might have. And the thinking is that the tattoo ink is somewhat irritating and inflammatory to the skin and the tissues underneath it. So they're just primed and ready to receive this inflammatory response from the sarcoidosis. And it's really kind of interesting. I have folks with tattoos, and they go, "Hey doc, my tattoo's flaring up again." I said, "Oh God, come in, let's take a look and examine you, get an x-ray, yada yada." And sure enough, the sarcoidosis is flared up. So the tattoos are kind of like the canary in the mine. They kind of warn us that something amiss is happening. It's this really interesting phenomenology. This is a very specific type of presentation on the skin. It's called erythema nodosum. And these red spots here are a lot like hives. People who have allergies sometimes get hives or urticaria in medical jargon. And this is not sarcoidosis here. If you biopsy these red spots, you're not going to get the granulomas. They are just a manifestation of the inflammation from sarcoidosis. These granulomas produce a lot of chemicals, if you will, a lot of inflammatory chemicals, and some of these chemicals can actually cause a hive-like reaction that produces this pattern of erythema nodosum. Okay, and that's important to note, because erythema nodosum is actually a good prognostic sign. People who have this robust inflammatory response are going to be folks who probably are going to get over the sarcoidosis quite well. It can affect our bones. And here we have some pictures of the hands, and here's the wrist over here. And you can see these rounded areas, these punched out areas in the bones. This is where the sarcoidosis is taking away the calcium in the bones. All right. You can see right here, these are the joint spaces in our fingers. What I'm pointing to are the areas where we can bend our fingers, our tendons are attached there. And you can see that they're pretty much preserved. Sarcoidosis doesn't really affect our joints. It's not like rheumatoid arthritis or osteoarthritis that we get as we age. It can certainly destroy the bones, the long bones in our fingers, you can see here, but it doesn't really get into the joints like rheumatoid arthritis. And the sarcoidosis in the bones can be quite subtle. And in fact, if we find it there and we don't see sarcoidosis anywhere else, if it's not in a place where it's really going to do harm to, like a bone breakage or like in your hip or something like that, we tend to watch it. We don't really need to treat this. Just because it's there doesn't mean it's doing any harm. Like for example, in this in the bone here leading up to the wrist, the humerus here. Sarcoidologists from long ago, this is in the middle of the 20th century. James and Williams, two famous sarcoidologists from the United Kingdom, looked at thousands of people from all over the world, the West Indies, from Europe, from Africa, and they sort of figured out these patterns here. They found that people who have arthritis, who have a lot of joint pain, which some of you may have experienced with a sarcoidosis, people who have this hive-like reaction, the enodosum, people who have those big potato nose, the stage 1 scatting that I showed you, if you have this combination, remission is really quite high. We can treat the arthritis with like ibuprofen or other anti-inflammatories. Let's just treat the symptoms, and we watch and wait, monitor, and a lot of folks who present like this are going to get better on their own. Once we start getting into the more extrapulmonary parts of the body where the sarcoidosis is affecting, like the heart, the nervous system, the liver, and the bone, the chance of remission drops down. So we have to be very careful in these situations. Is it really doing harm to the patients that we're following? Do we need to jump on treatment with steroids and other medications that we can discuss here shortly, which of course, as you may know, have their own side effects, and especially if we're using them for a long time. So we have to be very careful when we commit a person to therapy for sarcoidosis. Do we really need to do this? This just drives home, again, the kinds of things that we look for that help us decide on whether to treat or not, or how to treat or how long. The chest film stage, the scatting stages, again, as I said, stage 1, 2, 3, 4. I won't belabor that, But again, you can see that improvement tends to be better in stage 1 and diminishes as we move down the stages, or the types, if you will. Good prognosis if you're a young person with sarcoidosis, if you have a stage 1 film, if you have acute eye problems like pain in the eye, redness in the eye, you have the edenodosum, that, believe it or not, the more symptomatic you are, the better chance that the sarcoidosis is going to resolve on its own. And Dr. Lofgren, a Swedish physician, recognized this syndrome, and it's now named after him. And believe it or not, many studies looking at treatment for sarcoidosis exclude these individuals because we know they're going to get better. So why do we have to involve them in clinical trials for certain therapies? So Lofgren syndrome, these folks who are going to do very well are pretty much excluded from clinical trials because we anticipate that the vast majority are going to get better. Who are the people that may do worse? Well, they tend to be older. As I've already mentioned, African Americans or people of African background tend to do worse. We can have when it's involving the kidney and causing hypercalcemia. The sarcoidosis granulomas make a lot of very potent vitamin D, so we absorb too much calcium, which can cause kidney stones. It can cause rhythm problems in our heart. So that tends to be one that we really have to pay attention to. And then, as I mentioned, if we have disease outside of the lung in other parts of the body, that tends to tell us that the disease is going to be around for a long time, and we better think about treatment strategies in those conditions. What are some of the routine things, whether I see a new person in whom we just made a diagnosis, or in people who had sarcoidosis and they come to me and they say, hey, is my sarcoidosis active? There are several things we can look at in the blood that can give us an idea if that inflammation is active. The lymphocytes are a type of white blood cell that are very important for our immune system. And when we have sarcoidosis, those cells are called into the tissues. So then we're going to see fewer and fewer of them in the blood. So if we have low lymphocytes in the blood, it's telling me that, hey, these lymphocytes are being called into the lungs, they're being called into the liver, the heart, whatever, to fight something. And it would, the sarcoidosis. And so it would say, maybe the sarcoidosis is active. We can look at the red cells. There are problems with our red blood cells that can give us an idea that the inflammation might be active. Calcium and vitamin D levels are very important to help me decide if the sarcoidosis may be active. Then these types of proteins that are called acute phase reactants, which measure inflammation, like the sedimentation rate. There's something called the C-reactive protein that can be very high. And some of these inflammatory proteins are associated with some of these other symptoms that people with sarcoid get. And in fact, fatigue, by far, if you go on the Foundation for Sarcoidosis website, then you'll see a registry where people have put in their symptoms and so on. Fatigue is probably one of the most common, if not the most common symptom that folks with active sarcoidosis are going to experience. We've learned that, and that's an important thing to look for. Creatinine is a chemical that tells us if the kidneys are working well. Liver function tests let us know if the liver is inflamed. And then this last thing you may have heard of is called the ACE level, or the angiotensin converting enzyme level. Sarcoidosis makes a ton of this stuff. So if it's elevated, it's a very good marker to tell me, if the person has active sarcoidosis, are they responding to therapy? So if it's elevated, and it's not elevated in everybody, if it's elevated, it's a very good marker that helps us follow sarcoidosis, a good objective marker. So in the end, what we have to do as sarcoidologists is this. All right, when it comes to treatment, we have an individual who has sarcoidosis. We need to recognize the danger signs. Is it affecting the heart? Is there a heart rhythm problem? Is there a lung problem? Do the lung function tests show that there's something going on? Are they very symptomatic? When we see these danger signs, then we got to think about a treatment strategy. Okay, you have to have expertise. I think that in a very simple case of sarcoidosis, perhaps a good pulmonologist who's gotten good training recognizes it and can say, I can take care of this. I can monitor. This individual might get better, but if that doesn't happen, I strongly recommend our colleagues to send folks to groups like the group we have at Jefferson, like the group at Mount Sinai, National Jewish, and many other places who really focus on this condition, to get that extra expertise to really dig down deep and understand better what's going on. And do we really need to treat, and how should we treat people? It's multidisciplinary. I don't think, you don't need a cowboy out there to say, I can take care of all the sarcoidosis. I'm a pulmonologist. If it's in the brain, don't rely on me just to treat it. I'm going to get you to my colleagues who I know and have treated sarcoidosis with me who are neurologists so they can get involved. Very important, the multidisciplinary approach. Shared decision making. This is something we're teaching our medical students and residents and fellows these days. Back in my day, I trained back in the 70s, and really, up until that time, it was, the doctor does this, the doctor says this, you do what the doctor says. That's not the case. We have to talk to our patients. We have to bring them up to speed, educate them as much as possible. And the treatment decisions we make have to be made together. I may have an individual who has diabetes, and if I put him or her on steroids, I may make that diabetes worse. Let's talk about that. We can talk about the dosing. We can talk about other medicines like methotrexate, azathioprine, that we can use as a steroid-sparing agent. So we have to make these decisions together. You shouldn't just, okay, doctor, I'll do what you say. No, it has to be a decision-making, and that's really important. And, life is complicated. Biology is complicated. We always need a little luck, right? So, we have to hang in there. We have to continue to communicate. The sarcoidosis, like many other diseases, is an evolving thing. It gets better, it gets worse, it stays stable. We got to stay in touch with individuals. Life is very busy. Patients with sarcoidosis, many of them are in that stage of their life where they're working. They're the breadwinners for their family. They're going to baseball games. They're coaching. They're doing all sorts of things. So it's tough to manage a chronic disease and then stay engaged in life. So it's really important to stay up to date. This is my concept of how we need to manage sarcoidosis, and what I'm doing here. I've only been here a couple of years putting a program together at Jefferson, but what I like to see ourselves is it's the sarcoidosis home. It's a disease that pulmonologists own because we see it in the lung, but we need help from all of our colleagues who have the expertise in all these other areas. It's a conversation back and forth, and for example, in cardiology, I have a great relationship with our cardiologists. We have 2 or 3 who are very, very interested in sarcoidosis of the heart. Ophthalmology is a big thing, of course. Not only should we be engaged with all these folks in treating our patients with sarcoidosis, managing them, but we also need to be engaged in clinical trials and translational scientific trials like we're doing here at Jefferson and in other places. And then, we need to engage people in all of the societies, things like the support groups like this are very, very important. The World Association for Sarcoidosis and Granulomatous Diseases is all over the world. We are a WASOG clinic here at Jefferson, for example. The Foundation for Sarcoidosis Research is funding my trials, and that's another good resource. There's a Bernie Mac Foundation in his honor as well, and they're very engaged in a very specific way, actually out of the University of Chicago, for example. They support their endeavors there in sarcoidosis. So I think it's a condition that probably is more common than we think. The prevalence is thought to be about 200,000 in the United States. It's not an orphan disease, but it's not a common disease. It's kind of stuck in the twilight zone there, but I think it's much more common than that. And in the end, I just would entertain any questions that you might have. And thank you for listening to me, and hopefully I've kept you awake. So I'm going to stop sharing now, and we can discuss.
Okay, well, thank you so much, Dr. Perez. That was very educational, and I think it gives us a lot to talk about here. The first question I had was, is sarcoidosis known to be hereditary? And if my sibling has it, should I get tested?
Okay, there are predispositions. It's really interesting. When I was at Emory University years ago, we did a study, and we found that in about 29, not quite 30% of our African American patients, they had a relative, either a sibling, a cousin, an aunt, or a parent who had sarcoidosis. So it's not that it's inherited, but there are predispositions. In our Caucasian population, about 5% of individuals had relatives who had sarcoidosis. And I don't want to get too wonky here, but in our chromosome number 6, we have 23 chromosomes in our body. There's a little piece of our chromosome in the short arm. It's called the human lymphocyte antigens. And these are the place in our bodies that regulate our immune response. And what we find is that in people who have sarcoidosis, they tend to have certain, what we call polymorphisms, certain types of these HLAs, certain signatures that make them a little bit more predisposed or susceptible. So there may be a susceptibility issue, but really there's no screening for sarcoidosis. It's just not something that we would screen for. It's just not it's just not cost effective. It's just not worth the cost or the trouble of drawing bloods or irradiating people just to find the sarcoidosis. So there is no screening for sarcoidosis. But yes, there is a predisposition. There can be some familial predispositions. Not mean you're going to get it. It just means that it may run in the family. Yeah.
So if, for example, a relative of mine was having lung issues, that might be the conversation to have with the doctor, saying, "Hey, I have a brother who has sarcoidosis. Can we, not exclude that until we know otherwise?"
Absolutely, absolutely. And what we do in medicine is we generate what's called a differential diagnosis. So you come to me with shortness of breath. I ask the questions, we talk, we do things, and then in my mind I'm sorting things out. So let's say you were a smoker for 50 years and you're short of breath and wheezing. I'm not going to be thinking sarcoidosis. I'm going to be thinking COPD or emphysema, right? But then you tell me, I have, and this is true. I have one woman who had 4 sisters, and all of them had sarcoidosis. So if you tell me I have 2 brothers with sarcoidosis, I'm going to go, wait a minute. Sarcoidosis can also affect our breathing passages. It can cause us to wheeze. It can cause us to be shortness of breath. So I'm going to put that in my differential. Even if you were a smoker, I'm going to say, I'm going to think a little bit harder about sarcoidosis, right? So that's why it's so important to have a conversation. And there are no stupid questions. There are no silly answers. We got to talk and we got to hear what people have to say, and that helps us kind of shuffle in our minds what's going on, and then we can direct the appropriate blood work, the getting chest X-rays, CT scans, that kind of thing. So 80% of what we do in medicine is the exchange, understanding what we learned in medical school about symptoms and different diseases, and then putting that story together when we listen to a person who's having symptomatology. So that's how we need to approach sarcoidosis as well. But yeah, please let us know. Please let your doctor know if you had sarcoidosis in the family. If a family member of yours doesn't have sarcoid and you have sarcoid, tell them, hey, tell the doctor when you're short of breath that you have a family member with sarcoid.
Okay, thank you very much. The next question we have, and this is a note to everyone out there, now's the time to type your questions into the chat window, and we'll process them and get them to the doctor while we have his full attention here in this meeting. So the next question is, you showed images with the scatting stages.
Yes.
Were those X-rays or CTs?
Those were regular chest X-rays. They're the very simple, quick ones that can be done in just a couple of minutes. And Dr. Scanning did this in the 1950s and 60s when the CT scanners weren't around. The CT scanners came out around in the 1980s. If we were to CT scan a lot of these different stages, what happens? I mean, at stage 1, we might actually see with a finer detail of a CT scan more stuff in the lungs, if you will, not just the lymph nodes. And so, yeah, people are thinking about that. How are we going to segregate now based on CT scans relative to what Dr. Scanning did so many years ago? But I tell you, the scanning thing has really held up strongly. So when I first meet an individual who I think has sarcoidosis, I'm going to get the basic blood work. I'm going to get an EKG. I'm going to get a regular chest X-ray. In fact, some insurance companies won't pay for a CT scan until you do a chest X-ray.
Right.
And that can be very informative. So that's a very good differentiation. Those stages are done with regular chest X-rays, not a CT scanner.
Okay. And the follow-up question is, the person answering the question cannot have the contrast,
right,
for the CT scan. So,
right.
What do you do in that case? Do you need the contrast to show the detail in sarcoidosis, or can she do it without contrast?
Okay. Quick answer is no. We don't need contrast anymore.
Okay.
Earlier on, we used contrast because what that does is it lights up the blood vessels that surround the lymph nodes and everything else, and it was much easier to see the lymph nodes better with the contrast. So that will do that. But nowadays we use something called a high resolution scan, which allows us to look at very tiny structures in the lungs, and it doesn't require contrast at all. And so we do not use contrast. We use a high resolution scan. It can tell us a lot about the lungs, and we can still see the lymph nodes fairly well. So that we don't need to use contrast anymore for sarcoidosis. No, we don't.
Okay, that's great news. I had a follow-up question with that. We were looking at um, the sarcoidosis when it was showing up on the X-rays, and it shows up as white spots.
Yes.
If you have neurosarcoidosis, would those same spots be showing up in your brain?
Right. So what I showed you on the brain is a different imaging technique. It's called nuclear magnetic resonance imaging. Basically, we put a person in a huge magnet, believe it or not, and the
Yeah.
magnet whips the molecules in our body around, and then we release the magnet, and the molecules whip back, and then this creates an energy that that our sensors can see, and then we use the computer to reconstruct the image. So it's not like looking at an X-ray, like a CT scan, which uses gamma rays, right, or a plain regular chest X-ray. They use different types of radiation. An MRI does not use radiation. It's not a radiation technique at all. You're not irradiating somebody, which is a nice thing. So it shows us different things. But where you see those white spots, that's where the inflammation is. That's where you have the granulomas, whether you're doing a CT scan or an X-ray for the lungs, or you're looking in the brain. Those white areas represent the inflammation that is that granuloma that I showed you, that nice little juicy spherical inflammatory lesion. It's called the non-caseating granuloma that defines this disease.
Okay, great. Thank you. So can you walk us through the treatment, the sequence, if we have chronic sarcoidosis and need to get on steroids, how can we get off of them, and what do we look for?
Okay, right. So again, the word danger is becoming very popular in the sarcoid world for us. When we see a patient and we present a patient, the question that we will ask is, well, is there a danger to any of the organ systems? Are their lung functions good? Is the heart doing okay? Or is their blood work fine? Their liver working okay? Is their eye exam okay? Okay, we got the sarcoidosis. The patient is doing fine. They're not in danger. Then we don't want to treat if we can avoid it, because as many of you may know, steroids have a lot of side effects. They're wonderful life-saving drugs. They really knock down that inflammation quickly, right? They induce a remission of the sarcoidosis. But what they found over the years, that if once we start coming off the steroids, sometimes the sarcoidosis will kind of come back up, right? And then we have to go to other medications like methotrexate and other medications. So what we want to do at the beginning is there a danger? If not, let's monitor carefully. What we found that if in the first 2 years of diagnosis, the person gets better, the disease goes into remission, we call that acute sarcoidosis, and the chances are very good that that individual is over it. It ain't coming back, okay? After 2 years, if the sarcoidosis is still active, we call that chronic, because what we've seen in our studies and our observations is that if the sarcoidosis is alive and well after 2 years, we're probably going to, extend it out. It's going to be there for a long time, and then that definitely needs to be treated. So that's how we make our treatment choices. Over the years, we've found that we don't need to use as much steroids as we have to. Back in the day, we were really hitting people hard with large doses of steroids. These days, for example, around 40 milligrams a day to start is a sufficient dose. We don't have to do that. Exceptions are if we have it in the brain and the person is acutely ill, they're almost, they're having a lot of symptoms in the nervous system, we'll do what's called pulse therapy. We will actually do intravenous therapy with up to 1,000 milligrams at a time. We can give 1,000 milligrams a day for like 3 days in a row, and then go with other steroid-sparing medications and so on. So for heart and neurological sarcoidosis, we probably hit hard with steroids up front. It's really important to get control. The heart has to beat every, 80 times a minute, 70, 80 times a minute. We got to get that better fast. The brain's got to work so that we can work. We got to hit that fast. So we really are aggressive in those specific areas. High calcium, hypercalcemia can be a problem. It can cause heart rhythm problems and the heart to stop. We got to hit that hard. So when we see an immediate danger to the body, steroids are the way to go to start. And then what we try to do is we can try to carefully start weaning the steroids and see if we can maintain that response. But if we see the sarcoid coming back, then we have to go to other medicines like methotrexate, azathioprine. There's some biologics. A common one is Remicade or infliximab. It hits a certain chemical in our body called tumor necrosis factor alpha, which drives this granulomatous response. Um, these are the kinds of things we have to do. Sometimes we have to go with heavy hitters like Cytoxan, mycophenolate. All of these drugs can be life-saving, but they're a double-edged sword. A lot of side effects can happen with these medicines. We have to monitor the blood work carefully. We have to understand, are you getting sores in your mouth? Are you getting GI upset? You know, we have to be very careful with these medications. So it's really, really important to understand the danger signs and where's the danger coming from, and tailor the therapy to that. So yeah, it's you know, you need the expertise. You need to really be thorough, and talk to the individual and say, here are the options that we have, and let's go with this. And it's very important to follow up and you know, and then manage these diseases carefully and manage the potential problems with these drugs carefully as well.
Okay, thank you. That was very, very useful. So the next question is, what was the test mentioned that can be an indicator of the prevalence or severity of sarcoidosis?
Well, I maybe you
In the ACE test?
ACE level, yeah, the angiotensin converting enzyme. So that fancy term, we all have angiotensin converting enzyme. It's very important. And what enzymes do is that they speed chemical reactions really, really fast. If you sit and watch anything, something's going to change. If you can wait a billion years, everything's going to change. Enzymes make things happen really, really fast. And angiotensin is a very important chemical in our bodies to help regulate our blood pressure. Okay, so it has to go through several steps, and the enzymes convert angiotensinogen, which is kind of sitting around doing nothing, into angiotensin, which is active. Sarcoidosis, those granulomas I showed you, those inflammatory little balls that I showed you, that little sphere, for some reason they make a lot of angiotensin in some cases. So it can of the enzyme in some cases. So if the enzyme is really high and you have sarcoidosis, it tells me that the sarcoidosis is active. And typically when I treat you with prednisone, for example, or other steroids, that angiotensin level is going to drop. And what that tells me is if I'm knocking down the angiotensin enzyme level, then I'm probably doing something effective to reduce the inflammation from the sarcoidosis. So it's a good, what we call, biomarker. So I can check that in the blood. So you come back to me in 3 months after we've started treatment, I check your ACE level, and now it's down. That's a measure that says, hey, the therapy's working. Your inflammation is going down. Does it correlate with how you feel? Are you breathing better? Are you feeling better? Is your joint pain gone? Etc. So it's just an objective measure in sarcoidosis that's very helpful if indeed it's elevated. If not all individuals have a high ACE level, but if it's elevated, it's a really nice marker that helps me understand if the therapy is working.
Okay, I was going to say, I had a very bad flare-up last year. That's when we got together the first time. And I don't think my ACE levels ever were elevated. So it sounds like it's in some people and not in others.
Right. So in your case, I would not rely on an ACE level to tell me if the disease is active or not in your particular case. Yeah.
Yep. Okay. Thank you. Next question. When sarcoidosis goes into remission, do the granulomas shrink or do they remain the same size?
Excellent question. So shrink is a good way to put it. The granulomas become less active, and they actually scar up. They fibrose. They kind of shrivel. They do. I mean, shrink is a good word to describe it. So if you do a biopsy on someone who doesn't have active sarcoidosis, which is very uncommon, there's no reason to do it, and you look under the microscope, all those cells, all those blue nucleuses, everything I showed you that was really very active is really calmed down. And sometimes you see these little whorls of thread-like things that are called scar. So the granulomas tend to involute and shrink down, and they become very quiet. So yes, we can. That's what happens to them when you go into remission. And the longer a person is in remission, the less chance that they're going to relapse. But we do have cases where people go into remission and they can relapse. So going back to that thing about the 2-year benchmark for acute versus chronic. After 2 years, if the disease is not active, we need to watch for at least 3 more years, at least once a year, 3 more years, to see that the disease stays in remission. After 5 years of the disease being controlled and not coming back, the chances of it coming back are extremely low. So we have this kind of 2-year benchmark, and then we have a 5-year benchmark. If after 5 years everything is calm and cool, chances are that go on to live to be 100. It's done. It's in remission.
Okay, thank you. Next question. Not sure how common recurring kidney stones are. However, I have had 14 times, 13 lithotripsies. I'm not sure if I'm pronouncing that correct. And currently have another one. The last episode caused sepsis in a hospital stay.
Yeah.
Has it ever been linked to sarcoidosis?
Right.
What would you advise?
Right. So kidney stones are so common. I mean, most people who have kidney stones do not have sarcoidosis. However, if you have sarcoidosis and you have a problem with the calcium metabolism, you can get you have a greater chance of developing kidney stones. Now, we have to be careful because kidney stones come in different forms. Some of them are calcium, some of them are urate. They come in different forms. So you may have a kidney stone that is not related to calcium at all and could certainly be from another unfortunate cause. People get kidney stones for a lot of reasons. So just because a person has sarcoidosis doesn't mean that everything that happens to us is due to the sarcoidosis. So it depends on the types of kidney stones. But yes, for sure. I mean, if your calcium levels have been high, the sarcoidosis is out of control. Sarcoidosis can affect the kidneys. It affects calcium metabolism, and then certainly can be related to the kidney stones. Lithotripsy is a non-surgical way of kind of with sound waves. You go boom through the back, bust up the stones, and you could get them, the urine. They can come out in the urine better. That's what a lithotripsy does. So yeah, I'm sorry that individual, whoever you are, who has all those kidney stones, because I know they're very painful. I haven't experienced one myself, and I hope I never do. But I've seen people with kidney stones, so I can empathize with you.
Okay. Next question is, let me see, I'm trying to get them in order. What causes low vitamin B12 levels in patients with sarcoidosis?
Low vitamin B12. Well, I'm not, vitamin B12 is what we call a soluble vitamin. It's something that we have to continue to take in through our diet. It's stored in the liver. And we can store, let's say that your liver is nice and plump with vitamin B12, and then I stop your vitamin B12 after 1 year, you're going to be deficient because we use it up. I don't think that there's a specific linkage to B12 deficiency and sarcoidosis, but certainly if the liver is inflamed, it's not going to be as efficient in storing things and doing its job. So there might be a deficiency there. Where the vitamin we really see go out of whack is the vitamin D. Vitamin D levels, they can actually the total vitamin D may be quite low, but then the active vitamin D that's made inside of the sarcoid granulomas can be very high. So people can actually have too much vitamin D, even though we measure the total vitamin D in the blood to be low. The sarcoid is making a lot of what we call calcitriol, which is the active vitamin D. So we have to be very careful with our vitamin D. If you have active sarcoidosis, you probably don't want to be taking vitamin D supplementation because it make it go too high. You may retain too much calcium, causing the stones and hypercalcemia and other problems. So we have to be cognizant of that. On the other hand, once we successfully treat the sarcoidosis, then we need to readdress vitamin D. Because, if your total vitamin D was low and now we've taken care of the sarcoid, we need to understand what the levels are, and you might need supplementation after that. So again, this is a very dynamic condition, right? I mean, it can be very active. We take care of it. It can go into remission. It can relapse. It's a moving target. So we have to be on top of it all of the time. Yeah.
Okay, thank you. Next question is, if the chest lymph nodes, the hilar lymph nodes, are enlarged, but the lungs are clear,
Yeah.
do we recommend, and the other organs are clear, so it's just in the hilar lymph nodes, I guess that's stage 1.
Right.
Is it more risky to take the steroids or to monitor it and take the risk that the granulomas are going to spread into the lungs or other areas?
Right. So it's an easy answer. No, if you have a stage 1 and nothing else, there's no danger to any organ. We've done the lung function testing. The big lymph nodes are not going to affect your lung function. The lymph nodes don't impede the air and anything like that. My recommendation is to watch. And in that first 2-year period, at the very least, we need to get together at least every 6 months. So we understand the disease is there. We understand that you're safe. Your eyes are fine. Your EKG is fine. Your lung function is fine. Your blood work is fine. You come back in 6 months and we reassess. And we do that every 6 months for 2 years. If you're nice and stable, let's have a party because you're probably going to do well. And especially if everything's gotten better, maybe the lymph nodes have shrunk, you're better. The thing is, to me, is why do you get sarcoidosis? It's your body trying to fix something. There's something in the environment that you're breathing, and your body's reacting to it. So we don't want to kill that sarcoidosis right off the bat. There's something going on in there, and maybe it's trying to do a good thing. So as long as the sarcoid is not affecting your body or causing danger to you, let's let it do its job. There's some bug or something out there. We think it might be some special type of mycobacterium, some type of bug to be, but I don't want to get tangential into that. So I may breathe the same thing you do, but I'm not susceptible to developing sarcoidosis. I may get a reaction that's so mild that I don't feel it. I never go to the doctor, and then my body takes care of it. People with sarcoidosis may just be super immune, they just have a super immune system. People have talked about that. People with sarcoidosis just have a super high immune system, and boom, they inhale the same thing I do, but there's this robust reaction that manifests itself as sarcoidosis. So we want to be careful. It's a balancing act. It's a balancing act. So stage 1 with nothing else going on, I'm happy. Just please don't go away and not come back. Let's keep track of it. I don't want to put you on any drugs that are causing side effects.
All right, thank you. Next question is, I've heard of some people talking about skin itching or tingling can occur. Is this a sarcoidosis symptom or is it more parasarcoidosis? And is there anything to help with the itching?
Yeah, no, that's very, very intuitive. That's very good. So I didn't really show you this on when I was showing you the slides about the central nervous system and the cranial nerves, the facial, but there's a condition that's called small fiber neuropathy. And it can occur in other conditions besides sarcoidosis, but these are the tiny, tiny little nerves that permeate our skin through our dermis and into our skin. And what happens in many inflammatory conditions, not just sarcoid, but also in sarcoidosis, is that the inflammation kind of knocks out these little nerves. And things, and people can get what are called paresthesias. They get neuropathies. You can get tingling. You can get loss of sensation. You can get paresthesias, meaning things that you shouldn't be feeling. You feel like itchiness, burning, things like that. So yes, small fiber neuropathy is a condition that's been very well described in sarcoidosis. It can happen like what we call stocking glove. It can be like the hands and maybe up to the arm here. It can be up ankles and up halfway through the calves, but anything above that is okay. Or it can be patchy. It can be in different patches throughout our body. So you have that type of manifestation. So neuropathy does happen in sarcoidosis, and when you do the biopsies on the skin, you see the knockout or the dropout of these nerve fibers that can certainly cause this, this problem with the sensations that you're describing.
Okay, so next question, high calcium levels with sarcoidosis. How is that happening, and what can we do about that?
Right. So the high calcium levels are because the granulomas themselves are making they're making the active form of vitamin D. Vitamin D, whether we take it through our food, it is not active at all. It actually is activated by sunlight. Ultraviolet rays hit our skin, and then they activate vitamin D to become active. And then active vitamin D goes to our belly, to our gut, and allows us from our intake of calcium through our food and so on, supplements, to absorb more calcium. So when sarcoidosis is very active and making a lot of active vitamin D, which is called calcitriol, it causes our gut to absorb a lot of more calcium than it should. So calcium levels can go up. And when that happens, it can deposit in our tissues, hence the kidney stones. It can get into the heart muscles and kind of throw off the electrical system, and people can get rhythm problems in their heart. And the calcium levels are really high. That's an emergency. We have to bring people in. We got to pump you full of fluids and Lasix, and we got to, give you medicines to stabilize the heart rhythm. So it's not that common that the calcium gets to super high levels in sarcoidosis, but it can. So it's very important to do that. It's very sensitive to treatment with steroids. Steroids easily bring the calcium back down, thankfully. And then there's another drug called hydroxychloroquine or Plaquenil, which is very good for controlling calcium in sarcoidosis. And it's also a good drug for skin sarcoid. It's one of the better drugs we use to control sarcoidosis of the skin.
All right. So I just wanted to let everyone know that we have about 25 minutes left. If you have any questions you'd like to bring out, please put them in the chat session. If you have asked a question and it did not get to me or get asked, then please repost it so it'll bring it to the top of the pile. Okay. In the meantime, I'm going to ask a few questions that came up from some previous groups that we had kind of tracked, and we'll put them out there now. First is you mentioned translational studies. What exactly is that doing?
Okay, so let's when we talk about medical research, you have the folks who are like PhDs. They're people that are doing work in the laboratory. They're working in test tubes. They're working with cell cultures. They're working in animal models, and they're studying at a very deep level mechanisms, things, how things work inside of our cells. What are the actual chemicals? How do things work in relationship? And that's called basic science. Okay. On the other side, we have what's called clinical research, and this is research where, because of basic science, we say, hey, we've developed a new drug that looks like it might work in treating a certain disease. So then you get to the clinical research scientists, basically more what I do, and this is where we go to the bedside. This is where we have the patients come in and we say, hey, we have drug A here, which we think is better than nothing, placebo, or we think it's better than drug B, which has been out for 10 years and it's kind of half and half working. We got a better drug. And then we will do clinical trials, and that's the other end of research. Translational kind of brings the two together. So that's in my funded study, for example, I have patients who come to me because of the sarcoidosis, and we're doing in patients who need to have bronchoscopy, where we go in and we do the biopsies to get the diagnosis. We wash out the areas in the lung to bring back the inflammatory cells. What I'm doing is I'm collecting this material, and I'm going to the basic lab. I have a colleague that I'm collaborating with, Dr. Roman, and what we're doing is we're looking at some chemicals in the body, biomarkers, if you will, in these fluids to see if we can predict which individuals are going to get better in the lungs, or who is going to develop that stage 4, the fibrosis, which is irreversible. I mean, stage 4, thankfully, is not the most common presentation or end result in sarcoidosis. About 5 to 10% of people who have sarcoidosis are going to have serious lung problems, and some may even have to go to lung transplant. So we need to understand, why do these people do this? Why do some people get scars and some people get better? We need to understand that. So when we get actually tissues out of the lungs, and of course it's people sign consent to allow us to do this, and they're approved by our ethical groups at the university and so on. So we're monitored. So that's what translational means. It's kind of going in between the basic science and the bedside to bring those two together in a way to translate with going in either direction, to understand better, to understand the mechanism of the disease and to understand better ways to treat the diseases. That's what translational research does.
Okay, thank you. Would you consider sarcoidosis as an autoimmune disease, or would you consider chronic sarcoidosis as a possible autoimmune disease?
Yeah, wow, you guys ask great questions. No, so autoimmune, auto means self, right? Yep. So things like rheumatoid arthritis or lupus, what's happening is that something is happening to some of the proteins in our body or in our joint spaces that our immune system says, wait a minute, you don't belong here. You are foreign. You are an infection. And so it creates an inflammatory response against our cells, against our cells, autoimmune. Sarcoidosis, as far as we know, and we do not believe that it's a reaction to something that happens to ourself. We believe the circumstantial evidence, the best evidence suggests that it's something in the environment that we inhale. So in that sense, it's not really an autoimmune disease, so, but it obviously involves the immune system, right?
Right.
It's really complicated because the what we believe are the early stages or the very symptomatic stages of sarcoidosis have a specific immune response. And for folks who progress to the more chronic stages, there is a switching in immunology that favors more of the scarring. So that's an area that we're just beginning to understand better and better. And some of the new therapies are really targeted at these very specific immune systems. So like I said at the beginning, hopefully we'll get into a trial. I'm really excited about this particular biologic, that might be really targeting some of these chemicals that drive sarcoidosis, but yet have a lot less side effect profile from these chemicals that we use, prednisone, methotrexate, all of them double-edged sword. They suppress the immune system, but they have a lot of side effects. So if we can improve the side effect profile of much better therapies, we're excited about that. I think that's the direction we're headed in.
What would your advice be to someone who's been diagnosed with sarcoidosis with respect to nutrition or diet and fasting or intermittent fasting? Is there any studies or recommendations on what to eat and not eat?
Right. So, yeah, there's really not much information. There's not any evidence-based information about specific diets for sarcoidosis, but the people who do talk about it talk about going onto an anti-inflammatory diet, a diet that's not full of carbohydrates or sugars. Remember, sarcoidosis is a high-energy inflammatory reaction. It loves sugar. Sugar is the fuel, that drives a lot of our metabolism. So things that, for example, cherries or tomatoes, they have certain anti-inflammatory components. So staying with vegetables and fruits, avoiding processed foods, avoiding a lot of carbohydrates, things with a lot of sugar are probably the way to go. So yeah, I think those are the general recommendations for inflammatory conditions to control them in general. But there's no studies have been done with, okay, you guys eat this, you guys get Taco Bell, you guys get Burger King. I mean, no one that study.
I wouldn't sign up for either of those groups.
Yeah, whatever. Yeah. But again, a healthy diet, avoiding a lot of carbs and high fructose, high glucose is the way to go.
I've read that intermittent fasting and fasting in general can be good to control inflammation. So I feel I've had some very positive results with that, and we'll see what anyone else says.
Right. Well, our bodies are circadian. I mean, in every 24-hour cycle, things really dramatically change with respect to, like, for example, our adrenal glands make a lot of hydrocortisone in the morning time. That's the best time to take the prednisone to avoid side effects. Is the best time to take steroids is in the morning time after getting up, right, with some food. That's by our circadian rhythm. So yeah, this intermittent fasting and these kind of long intervals that people have talked about do a reset. And we're not really designed to be eating constantly.
Right.
We're not. So fasting has its benefits. Probably has some anti-inflammatory benefits. Yeah.
Okay. And I can attest to the carbohydrates. When I went on an Atkins style diet, it shrunk the inflammation that I had in my finger, which is where they first found the sarcoidosis. So I had a lot of very positive effects cutting carbs out, and have tried to adhere to that over the past decade as I've been dealing with this.
Yeah. Would it be okay if I share something real quick about that?
Sure.
Absolutely, Amy.
Thank you. And the reason I'm sharing it is I just got off a meeting with, I have cardiac sarcoidosis, and I just got off a meeting with, I asked to talk to a dietitian. So I had my, I go to Mayo, and I just got off my Zoom meeting about an hour before. meeting with the dietitian, and everything you said was exactly what she said. But so people maybe understand the term, she talked about the Mediterranean diet was a good diet for this situation.
Right.
So I just wanted to share that.
Yeah,
I'm with that as long as you stick with organic food.
I believe in olive oil. That's what I do. That came from I'm from Spain, and that's all we use in Italy and Spain and all that. We use olive oil based things and all those fruits and stuff like that. Yeah. Very good. Thank you.
Okay. The next question was around fatigue.
Yeah.
Why is sarcoidosis and fatigue so closely associated, and how can we unravel that? That's a tough one.
Yeah. The way I like to think about that is when you have a smoldering inflammation, it's kind of like, you had your campfire, you had your fun and all that, and you put out the fire, and you think that the fire's out, but the coals underneath are kind of smoldering there, just burning and slowly, and it's not obvious, it's not out here in front of your face, and it just sucks the energy out of you. So I don't purport to understand that fully, and there are people in other fields who are hopefully looking at that. There is a fatigue scale out there that some people are using in their clinics. I haven't implemented it yet, but it asks questions that relate to the fatigue, and as we treat the sarcoidosis, one would hope that the scale shows us that some of these symptoms are going away, but it's really tough to wrap one's head around. I know people with diabetes, it's uncontrolled, they have fatigue too. There's just so many. Chronic inflammation, chronic illness is not fun. It makes you tired. You get tired of it, you get tired of it.
Sick and tired of being sick and tired, yes.
That's right.
Absolutely.
That's right.
So I had chronic fatigue last year when I was going through my flare-up, and it was the worst thing I've ever been through. It was literally 4 months in bed. Just getting up to get breakfast, and I'm exhausted. It was terrible.
Right. That's right.
And now, I think with the diet and exercise and the fact that it's in remission, I'm feeling so much better. I've got more energy, more awareness. The brain fog's gone down. It really reminded me of long COVID. Are you familiar with that term?
Of course I am. I see it all the time.
It seemed to me that long COVID and sarcoidosis are like sisters. For whatever reason, they present very similarly with chronic sarcoidosis. I'm hoping with all the money that's being spent on COVID that there's some research that comes out that can actually help with the sarcoidosis community when it comes to fatigue and brain fog and some of that.
I think what we're trying to do with the long COVID for these individuals who are extremely fatigued, we do pulmonary function testing, we do their x-rays, pristine. Everything came back to normal, but yet so we're looking at like pulmonary rehabilitation things. It does help to practice the things that the virus made you forget. But what people are discovering is there's a dysfunction when we do things, when our body does stuff. It relates signals to our brain that says, yes, I have the capacity to do this. And what's happening is, even though your muscles are strong, you have long COVID or a chronic illness, you try to do something, there's a disconnect with the brain. The brain is saying, wait a minute, you're sick. Don't do this. So I'm going to make you fatigued. I'm going to make you not do this, even though you have the capability here. You got your muscle. There's a true functional disconnect, and people are understanding that better these days. There's very interesting types of MRIs that can look at the brain while you're listening to music or seeing something with different parts of the brains light up. So we can really understand better. We can make a person do something and watch the brain, how it reacts, and to see if it reacts normally or not. So there are a lot of people in the neuropsychiatry field, neuroimmunology field. The brain controls a lot of our immunology, and these are areas that are just starting to blossom in understanding. So hopefully we'll get some answers there. But I think doing something steady and practicing and doing rehabilitation, it's hard to get the insurance companies to pay for somebody to go to rehabilitation when everything looks normal, right?
Right.
The test is normal, the EKG is normal, the X-ray is normal. Why are you sending this person to pulmonary to physical rehabilitation? They're not going to pay for it. They're normal. They're fine.
Fine.
Right?
Fine. Yeah, that was really good. Thank you. Can you talk about exercise and pulmonary sarcoidosis? This person has extreme difficulty breathing when she tries to exercise. So what is the advice for that?
Right. Right. So when I hear extreme breathing difficulty, it means that probably this individual has quite significant pulmonary involvement. It may be into the stage 4, where it's the irreversible fibrosis. And what happens with scarring is this, like think of it like rubber bands. Scars are very elastic and they're tight, and you can't breathe against the scar. So the work of breathing, you have to work a lot harder to breathe. So that's kind of your limit. That's your ceiling. So what we do with pulmonary rehabilitation, it does not fix the lungs. The lungs are not a muscle. But what we do with that is that we condition the muscles, we condition the body to be more efficient. So it takes less oxygen, it takes less work. The lungs they can get more out of the muscles for the amount of work that they can do. So, for example, someone might be, they're deconditioned because they're not been exerting themselves very much. They may be overweight. So we go into a pulmonary rehab program where we deal with these things. We get them on the treadmill. We do the upper arm, ergometry. We have nutrition. We can talk to the individual and say, here's what's your diet like. Here's how we can modify this. Let's get you to lose some weight. So one of the mottos that we had in our program is build the body around the lungs. If the lungs are at a position where you can't get them back to where they were, back to normal, and they're going to be at a lower level, forever, work on the rest of the body. If your diabetes is out of control, get it tightly controlled. Give your lungs a break. Give your lungs the best body that they can breathe for. So that's really, really important. There are other things that we can do. Just don't think, oh, fix my lungs. Sometimes we can only go so far. Fix the rest of the body around it. Easier said than done, I know. It's tough. Losing weight is tough. Getting great control of your diabetes can be tough. I get it. Your blood pressure, sleep apnea, that is a huge problem. And people, that can really contribute to fatigue. So I always look in the throat to see if I got a crowded pharynx. Look at the Malampati score. What is your sleep hygiene like? Are you going to bed at a routine time? You shouldn't be watching TV in bed. You shouldn't be reading in bed. Bed is for sleep and other things. That's it, right? So it's taking a holistic approach to health, healing your body, and trying to do the best you can with other things will really help you increase your exercise tolerance, even if we can't make the lungs better.
What about breathing exercises? Are there specific breathing exercises that can help increase the surrounding support structure of the lungs to help them expand and contract? Because even though they may not perform better, you might be able to condition those muscles to do better.
Well, that's an area that's kind of nebulous. It's kind of a gray area. I mean, there are little tricks and tools that people use. A lot of athletes use these kind of resistance type of devices to make it, thinking that they can strengthen their diaphragms and their thorax, that kind of thing. The literature on that is kind of up and down. It's all over the place on that. But I think that, controlled breathing allows you to be in control better. And if you're not very active because you're short of breath, taking deep breaths will open up regions of the lungs that might otherwise become what we call atelectatic. If you're not really exercising a part of the lung, it tends to collapse down and get sticky and it won't open up. When you take a deep breath, you're opening up those areas. You're opening up areas that might not otherwise be engaged in breathing. So deep breathing exercises. I mean, if you do yoga, that's really good for controlled breathing. There's Buteyko breathing. You get online, if you get online on a YouTube or something and put in breathing exercises, you're going to see tons of stuff. You can't hurt your lungs by doing deep breathing or by doing controlled breathing. Sometimes deliberate huffing and coughing. A huff is like with the glottis. You're not closing your larynx. A cough is, you're closing your glottis, and that changes the pressure in the chest, mobilizing secretions, those kinds of things. So you cannot hurt the lungs by doing these breathing maneuvers. I think they're important, and I strongly recommend it.
Okay. The next question, and this, it's up to you. I know you're not treating this patient. I know he's asking for medical advice, so I'll just put it out there and you can decide what to do with that. So he recently has a definitive diagnosis of sarcoidosis. It's only a few days old, so it's all new to him. But he was told that his hilar lymph nodes and mediastinal lymph nodes are impeding on an artery. And the respirologist said not to treat unless it's causing symptoms, but he does have shortness of breath.
Right.
His heart rate is elevated. Is that all linked, and is that something that either monitor or maybe more aggressively treat?
Right. So in the vast majority of people, the actual anatomical location of the lymph nodes, when they swell, does not block an artery, does not impinge on a nerve, typically does not do that. The big swollen lymph nodes are just like, wow, they're there. They usually do not affect the airflow. They don't close down on our bronchial passages, those kinds of things. But on occasion, the swollen lymph nodes can actually get on a nerve. There's a thing, I have a woman I'm treating who has it impinging on what's called a recurrent laryngeal nerve, which is a nerve that kind of courses in the middle of our chest and swings back up and goes to our vocal cords, right? So sometimes the anatomy, you just get unlucky and it can compress on something. Now, if it's impinging on a vessel, the question then becomes, is it compromising the vessel? Just because it's pushing on it a little bit doesn't mean that the vessel is not working, right? And even sometimes when we treat the sarcoidosis and get rid of the inflammation, the lymph nodes don't come all the way back down. You know, they may still be elevated. They may still be enlarged. So, you know, what we have to do is look at lung function testing. We can understand how the blood vessels are working in the lung. Might want to do a treadmill stress test to see if it's impinging on heart function. So there are other things around it that we can look at to see if that lymph node that's impinging on the blood vessel is truly doing some harm. Again, if it's only the lymph node swelling in the chest, that's a type 1 or stage 1 scanning stage. That's the, you know, for the lungs, that's the best presentation. If the rest of the lungs are looking good and all you have is swollen lymph nodes, my goodness, the side effects from the treatments, you know, I don't know if it's worth risking it just to see if you can shrink that lymph node a little bit more. So yeah, if it's impinging on the blood vessel, is it compromising it? That's the big question. That's what the doctors have to answer for this individual.
Okay, a little bit of housekeeping. I believe we have some new people to the meeting today. So first of all, thank you for showing up. I hope this was helpful. If you could please post your email in the chat session, we will go and clean that up and put you on a mailing list that will remind you of upcoming events. So for example, on June 30th, we have a rare disease advocacy webinar. And that sounds like something that I'm definitely going to sign up for, but something that you would be made aware of through the ANCAN distribution list. So thank you very much for doing that. And I don't have any other questions. Dr. Perez, thank you so much for your time. This has been extremely informative. And I wish you the best of luck with your research. And like we talked about last night, we're going to definitely follow up with starting a support group out at Jefferson University Hospital. And I would be honored to be part of that.
Well, thank you so much. This is so good. I just learned so much from these questions. They're just so, you know, they're wow. You know, sometimes I hear a question I would have never anticipated, and that helps me too to learn more and be more helpful to the people I see that you know that share this disease with me, and I'm so, you know, thankful that I can take care of them. So thank you very much. This is just wonderful, and I hope to participate again. I'm going to
absolutely.
We have over 400 people with sarcoidosis in Jefferson, and we have a way that we can bring this group to them, and hopefully they will join this group as well. So we'll talk some more about that, Kevin. Yeah.
Okay. And before we say goodbye, is it possible for you to send me the slides and we will post them with the recording that will be available on the National Online Sarcoidosis Support site in Facebook.
Okay. Okay, and I have everything. Okay, yeah, I will. No problem.
Okay. All right.
Bye, everyone. Thank you for coming.
Okay. Thank you so much. It's been
Thanks,
extremely
Doc.
helpful. Best of luck.
Thank you.
Thank you.
All right.